So we're going to first start with Dr. Ray Cross, and he's going to give us a talk on positioning old and new therapies in IBD. Then we're going to be followed by the case, Crohn's disease case, that where we'll be discussing kind of the same way we did with the ulcerative colitis case. All right, thank you.
All right, thanks, Jenny.
Where's Dr. Rubin?
He's coming.
Oh, okay.
So I have the honor of doing the second to last talk before happy hour. So I'm going to try to put everything together. So the goals of therapy, regardless of what drug you select, are to induce clinical remission, which we can define as the absence of symptoms. We want to avoid short and long-term toxicities of therapy. Remission should be steroid-free, so we want to avoid repeated courses of steroids. If we do these things, we almost always enhance quality of life. If we do a treat-to-target strategy, we may be able to prevent complications, but oftentimes in IBD practice, a patient's going to be referred to you very late in the disease course where you need a colorectal surgeon or general surgeon to treat the complication. David already mentioned treat to target, so we should be trying to achieve mucosal healing. You don't have to be a mucosal healing fascist, so if you don't get there and it still looks better, sometimes that's good enough. And then in 2020, there's a heavy emphasis on decreasing unnecessary healthcare expenditures such as ER visits and hospitalizations. So these are our standard biologic therapies. This is in Crohn's. You're looking at infliximab, adalimumab, and certolizumab. And what I want you to focus on is the shaded blue. So this is net remission. So net remission is the response to induction. So those that respond then typically are re-randomized to placebo or maintenance with drug. And so whatever the remission rate is, you have to multiply it times the response rate. So you can see that the net remission here for infliximab, adalimumab, and certolizumab is approximately the same. So these are considered equally efficacious drugs for the treatment of Crohn's disease. I mentioned SONIC already. You can see clearly that infliximab and azathioprine are more effective than either infliximab or azathioprine alone, both in remission and mucosal healing. David already mentioned that if you're an optimist, this looks really good. But remember that over half of the patients have not achieved healing. If you actually look at patients that had confirmed lesions at baseline who were newly diagnosed, that number goes up to nearly 70%. So if you select the right patient early that actually has active inflammation when you start treatment, they do even better than what you see here. There's the most data for fistula treatment with anti-TNFs, particularly with infliximab. This is Accent 2, looking at one-year outcomes, and you can see that you can get fistula response in nearly 50% and complete closure of fistulas in just over a third. So we have the most data with infliximab for fistulas. And for postoperative treatment, again, most of our data is anti-TNF, and the bulk of it comes from infliximab. So this is the PREVENT trial, looking at clinical outcomes at week 76. So these were patients that had an ileocolic resection, and they were randomized to placebo or infliximab, standard maintenance therapy without induction. And what you're looking at, the primary endpoint is clinical recurrence at 1.5 years, and you can see that there's a trend in favor of infliximab in light blue. If you look at endoscopic recurrence, defined as a Root Gerd score of 2 or above, you can see that you're about half as likely to have endoscopic recurrence in the infliximab group. And then again, if you extend the clinical recurrence out to 2 years, you again see the same trend, but not a significant result. So I think this is still a positive study. If you actually take one area of the world out of this and run the numbers again, it completely would be as you'd expect. So, but again, most of the data on infliximab for post-op Crohn's. 3 slides on biosimilars. Biosimilars are here. You have to know about biosimilars. We have biosimilars available for infliximab. The ones for adalimumab are coming in the U.S. I'm going to show you 2 slides regarding efficacy of biosimilar compared to infliximab. This is looking at Inflectra versus Remicade. This is patients that were randomized at baseline to receive either drug, and you're looking at week 6 outcomes and 6-month outcomes, and you can see that they're equivalent. They then took these patients and randomized them to stay on the drug or to switch, and if you follow them for another 6 months, the outcomes are the same. So you take patients from the beginning, infliximab versus infliximab DYBB, outcomes are the same. One-time switch, outcomes look the same. This is the Switch trial, which is looking across multiple autoimmune states, and what you're looking at here is Crohn's disease on the left, ulcerative colitis on the right. These are patients that were stable on infliximab, and they were switched to the biosimilar, or they were maintained on infliximab innovator, and you can see that there's no difference in disease activity after a one-time switch compared to staying on the innovator product. So these are very reassuring. There's been other studies that are also out there that are reassuring for a one-time switch. We don't really know about multiple switches between innovator, biosimilar, and back to innovator. So we're going to talk about a number of novel agents. I'm going to skip this slide to be brief. So let's focus a little bit on vedolizumab. This is the second vedolizumab induction study for Crohn's disease. So what you're looking at on the left is week 6 remission rates, and you can see that there is improvement in the vedolizumab versus placebo. But if you follow patients out to week 10, that should actually be 28%. You can see that with 4 more weeks and 1 more dose of vedolizumab, about a third of patients are in clinical remission. Better with TNF-naive patients than TNF-exposed, but still a quarter of TNF-exposed patients were in remission. And I think one of the take-home points of this slide is that this sort of led into the idea that vedolizumab is slow onset of action. So those responders, which was about 40%, were then re-randomized to either every 4 weeks, every 8 weeks, or placebo. And you can see that placebo maintenance therapy with vedolizumab is superior. Vedolizumab active maintenance therapy is better than placebo across all outcomes. So this is ustekinumab. You're looking at the anti-TNF exposed patients on the top and the TNF naive patients on the bottom, and it's clearly an effective drug. You're looking at, I think in green here is IV induction. You can see that TNF exposed patients don't do as well. Every study basically shows the same thing, but the TNF naive patients tend to do very, very well. I have to fix my Keller scheme on that one. So again, the responders to induction go into maintenance, and again, the same message here. If it's every 12-week maintenance versus every 8-week maintenance versus placebo, maintenance therapy is superior. And when the approved maintenance dosing is every 8 weeks. So how do I position these drugs in Crohn's disease? So this is what I tell patients. I break it into 3 buckets. So onset of action. So if you want a drug that works fast, anti-TNFs are superior. So if you have a sick patient, you need to be better in a few days, you would choose the anti-TNF. I consider ustekinumab and vedolizumab more intermediate onset of action, thinking more in terms of weeks as opposed to days. If you look at mechanism of drug delivery, you have injectables. So you have certolizumab monthly, adalimumab twice monthly, ustekinumab every 8 weeks. And then you have your intravenous delivery methods with vedolizumab still currently is still IV alone or infliximab. So if it matters to the patient how they receive their drug, then you can choose one of those 2 mechanisms. And then lastly is safety. So if you look at safety, ustekinumab and vedolizumab are clearly the winners in safety. Infliximab anti-TNF monotherapy would be next. Thiopurine monotherapy would be, in my opinion, third. And of course, steroids are off the floor or below the floor. So that's how I talk to patients. The reality is they can pick whatever they want, but the payer is often going to decide what they're going to use first in a bio-naive patient. So this is looking at anti-TNFs for UC. This is just short-term induction, infliximab in yellow, adalimumab in red, golimumab in black. The point of this slide is to show you that with the sub-Q drugs with UC, they seem to be a little bit less effective. You're not supposed to compare across trials, but I'm comparing across trials, and in clinical practice, most of us feel the same way, that infliximab seems to work a little better for ulcerative colitis. Now, the data with vedolizumab in UC is a little rosier, looking at response and remission, as well as mucosal healing, just at week 6 is pretty good. And looking at the responders who then get randomized to maintenance therapy, this is by TNF exposure. Even the prior TNF exposed patients do pretty well with vedolizumab with UC. So David showed you this already. The only thing that's different here than what David showed you is I'm showing you endoscopic improvement as well as the steroid-free remission, which was actually not in favor of vedolizumab. I encourage you to look at this study. One of the hidden gems of this study is the onset of action of the drugs. So historically, we've thought vedolizumab is quite slow, but you actually see about 40% of patients after the first dose of vedolizumab are already responding, and by week 4, it's over 50%, and it clearly is outperforming adalimumab. So I don't think vedolizumab is quite as slow onset of acting as we've made it out to be. This is ustekinumab for UC. Again, this is short-term, 8 weeks. I think David showed this already. One thing that's different here is the FDA has now required us to look at histologic inflammation as well. So you're seeing some new definitions. Mucosal healing now is a combination of endoscopic and histologic, and now the old mucosal healing term is endoscopic healing. So you can see that with ustekinumab short-term, about 1 in 5 patients have achieved histologic and endoscopic remission. And then this is looking out at 44 weeks in the winners, those that responded, and you see pretty robust maintenance of response, remission, and mucosal healing with ustekinumab. David showed this already. Again, anti-TNF exposed patients don't do as well with even a small molecule, so I think it's more than just the mechanism. I think you have the best chance of response with the first drug, and this is the remission data that I think David also showed. Again, those that responded tended to do well in maintenance therapy. So safety's been emphasized somewhat already. So one thing to point out with the high-dose tofacitinib group is that the zoster rate's about 5%. It's even higher in patients that are on concurrent steroids and those that are Asian. And the serious infection rate is about 1, 2, 3% per year with tofacitinib. Coming back to pulmonary embolism, so to make those details about pulmonary embolism from the RA study a little bit more granular, the rate of PE in the anti-TNF arm was 1 in 1,000. In the low-dose tofa, it was 1 in about 330. And in the high-dose tofa, it was about 1 in 250, or the same rate of risk of dying in a car accident in the United States. So it is increased clearly, and it seems clinically meaningful, but the actual risk is actually quite small. So how do I position these therapies for UC? I put them into 4 buckets. So safety is still the same. You have ustekinumab and vedolizumab are the clear winners. Anti-TNF monotherapy is next. Combination therapy and tofacitinib perhaps may be equivalent. Thiopurines I still think are even a little below those. Well, monotherapy can't be below combo, so we'll put them all the same. And then there's mechanism of drug delivery. So you have an oral agent here. You have sub-Q agents, anti-TNFs, as well as ustekinumab. And then you have intravenous infliximab and vedolizumab. As far as speed of onset, the JAKs and anti-TNFs are fast. Vedolizumab and ustekinumab and maybe the sub-Q anti-TNFs are intermediate. And slowest here would be thiopurines for sure. And then as far as efficacy, head-to-head, we know comparing thiopurines to infliximab, that infliximab is superior and combo superior. We also now have one study showing that vedolizumab is superior to adalimumab. So if you have your choice between the two, I think you really should choose vedolizumab. So what about some special conditions? So what do you do about the elderly? First of all, how do we define the elderly? So the elderly definition changes as you get older. Many people use age 60, some say 65. I also think this concept of physiologic age is important. So a healthy, fit 72-year-old is probably different than an ill, frail 63-year-old. I avoid thiopurines in combination therapy in older patients, and I tend to start with vedolizumab or ustekinumab if possible. For patients with extraintestinal manifestations, this is controversial. So the EIMs that are driven by gut inflammation, it really shouldn't matter what mechanism you give them as long as you control the gut inflammation. But there are some that run an independent disease course. So I think there is a trend to use anti-TNFs or something systemic, like ustekinumab or tofacitinib in patients with extraintestinal manifestations compared to veto. Those with comorbid conditions, again, I try to avoid combination therapy. I start with safer drugs. and in women, avoid methotrexate and tofacitinib for now. The other drugs are all certainly acceptable during pregnancy. So to summarize in 20 seconds, there are more options now than ever for treatment of moderate to severe IBD. I think you should strongly consider ustekinumab or vedolizumab first line for patients with moderate disease or risk factors for a disabling disease course in the outpatient setting. For sicker patients, consider anti-TNF therapy, particularly those with perianal involvement. In the post-op setting, I think we have the most data for anti-TNF. Combination therapy versus proactive monitoring, I think that's where you would go. And I reserve tofacitinib for refractory patients or those that really value oral therapy over injection or intravenous, and for those that want to avoid a steroid bridge. The idea that you could use tofacitinib as pulse therapy is something that I think is going to evolve over time. So I'm 30 seconds over, but thank you very much.
Thank you. Thank you. That's a perfect summary that we needed. Okay, so now we're going to go on to the Crohn's disease case, and I promise I'm going to get you guys out in a reasonable hour. Okay, so this case is a 21-year-old male with a history of retinoblastoma as a child in remission. He's had chronic uveitis. He's had irritable bowel syndrome he has had partial small bowel obstructions now. So what he tells you is that he's had IBS since age 7. He's had waves of abdominal pain and constipation, and he presents 1 month before his first hospitalization of that partial small bowel obstruction. So he said he would have several days with 2 days of constipation, followed up by sharp epigastric pain, followed by episodes of nausea and vomiting with non-bloody diarrhea. He's unable to tolerate food, and he's had intermittent fever during these episodes. And these episodes of pain would go away after about 3 days. So after 3 of these episodes, he ends up at the outside hospital, and he has imaging and a colonoscopy done. So what's the workup that he gets? So he has a CT without contrast at first, and they say that it's compatible with the distal small bowel obstruction with fecalization of stool seen in the distal bowel loop. The site of obstruction is indeterminate. This is followed by an upper GI series, a small bowel follow-through, where he has distal ileal bowel loops that are dilated. There's 7-centimeter narrowing, and there's a little bit of, they say, mucosal regularity of the TI consistent with inflammatory bowel disease such as Crohn's. Clinical correlation is recommended. So the only labs we have are a CBC and a basic metabolic panel, so white count 6.5, hemoglobin's 11.6. Creatinine 0.83. We don't have any other inflammatory markers. And the colonoscopy that he gets, it describes a nodular terminal ileum with biopsies taken to rule out Crohn's disease. They don't mention anything about stricture. Punctate ulcers scattered and noted in patches throughout the colon, ascending colon, and sigmoid colon ulcers biopsied. And most of the colon mucosa appears normal and uninvolved with pathology. Recommendations are to await pathology and to start Pentasa given excellent small bowel coverage as well as large bowel. And you get the pathology back, and we get it reviewed here. It definitely confirms the IBD diagnosis with moderate active ileitis with moderate architectural distortion. Ascending colon shows moderately active colitis with minimal architectural distortion. The sigmoid colon shows mild focal active colitis with minimal architectural distortion. So he goes home on the Pentasa, 2 tablets 4 times a day, acetamin and iron ferrous sulfate tablets. So my question to the audience, to the panel, is how would you have managed this patient in the first month of diagnosis, given the findings on colonoscopy and small bowel follow-through? Dr. Cross?
So
what are your thoughts on his management?
So I like to win, and so I think the winning strategy here is when you have a patient with complicated disease, that you resect the pathology and you start from scratch in a patient like this that's young, he's higher risk for recurrence, but he doesn't have penetrating complications yet, so you could even consider no therapy with endoscopic surveillance. I think the dilation, the pre-stenotic dilation shows you that there's irreversible fibrosis present that's not going to respond to medical treatment. So I think this patient should have an ileocolic resection. It's not a long segment of disease. The surgeon or the patient may not agree to that, and if that's the case, I would probably pick a biologic, give him a biologic, but I probably wouldn't go to a second or third and burn through multiple classes of drugs to try to treat this fibrostenotic disease. Mm-hmm. The only thing that bothers me a little bit is they see a stricture and endoscopically they're driving into the TI, so that disconnect between the imaging and the scope does bother me a little bit. But But I think if there's truly a stricture there with pre-stenotic dilation, he's probably not going to respond to medical therapy.
Okay, that's good. So that's interesting. So he has episodes of abdominal pain that continue. What are your thoughts on his choice of Pentasa for the first treatment?
We shouldn't be giving Pentasa for Crohn's.
Right. I see it a lot, so it's just something that I want to make sure I drive home, that's definitely not a therapy that we want to consider for acute Crohn's ileitis.
Well, the other question really is, how do you know anything's going to work in him? What will you
Correct.
monitor? Because it sounded to me like he's had intermittent periods where he thinks he feels fine, and then he has these periods where he's having cramping or has some obstructive symptoms or even frank obstruction. So whatever you choose to do, whether it's an observation or a 5-ASA in this case, or what I would probably do, which would be a course of budesonide, and then if he's much feeling better and I had seen what I imagine was seen, I might have used a biological therapy for a while and give him one shot at it. He's never been on any medical therapy. And if I can fix that and he's doing great. I've had patients that look like they need to go to the OR out of the gate and they surprise me. So I would give it at least one shot. Now, it may be completely different if I'm scoping him and it looks horrible and I couldn't get the scope in. There is a retrospective study from the Mayo Clinic that says that 11% of patients with Crohn's will have disease that's above where you see with the scope. So maybe that's what they saw in the small bowel series. It's hard to know.
Okay, I think those are very important points. So I think the take home from that is that I think if you're going to consider a therapy first line for someone who seems milder, budesonide or prednisone probably is a better bet than using Pentasa to understand whether they have a high if they're going to respond to therapeutics. So the patient 1 month later is hospitalized and has right lower quadrant abdominal pain, this time with 8 pounds weight loss, nausea, vomiting again, 7 times before admission. He's passing gas, but his last bowel movement was the day before. He stops vomiting before he comes into the ER. He has a decreased appetite. His Tmax is at 102 a few hours before admission. And the labs that you get are that hemoglobin's at 14.1, his MCV 75, his CRP is elevated at 4.5, iron sats 15%, albumin's at 4.5. So he gets a CT with IV contrast, and the report suggests that he has a narrow distal ileum, roughly 10 centimeters long, with a long segment of dilated ileum proximally, with crowding of the distal ileum and sigmoid raising suspicion for fistula formation. And he does have a right renal stone. So audience, what would you do for this person who has partial small bowel obstruction, just kind of ER management? A, would you consider bowel rest alone? B, bowel rest with IV steroids in the ER, adding Cipro and metronidazole? Or D, IV solumedrol with antibiotics? Or E, using an NG tube dissection with IV solumedrol? So what would you do in this case, audience? Okay, so the majority of you would consider, I think, D, so bowel rest with IV solumedrol and Cipro and metronidazole. Okay, panel, what would you do in this case? So this is for an acute partial small bowel obstruction in the ER. They ask you, what can we start for this patient who has Crohn's ileitis and an obstruction?
Well, the CT suggested some penetrating features. I agree with the audience, the majority, that I would do D.
Okay.
Initially, just if he turns around immediately, then that supports going to something else. If there's not a frank large abscess, then I'm okay with managing him this way and getting him to a biological strategy.
Do you ever get concerned about using steroids in a patient that has possible fistulizing disease?
No. I mean, if he has an abscess, it's a little different, but not in this setting. I think it's okay.
Okay, so we're going to go on. So colorectal surgery is called. He has no vomiting, no NG tube is placed. He's placed on bowel rest alone, and after 24 hours, he starts to have small bowel movements. He's tolerating liquids, and he's feeling significantly better. And his CRP decreases from 4.5 to 2. He has an MRE at that time to better understand what's going on in the small bowel, and it shows that he has this, it's pretty similar to the findings he's had earlier, acute on chronic inflammation, distal TI, and roughly 10 centimeters centimeters with focal penetrating disease involving the adjacent loop of sigmoid colon. And then there is narrowing with upstream dilatation of the small bowel, consistent with partial small bowel obstruction. So Dr. Limketkai, does the fact that he has a fistula here, does that change your ideas on whether this person should go to surgery or consider medical management?
Well, but currently he has, I mean, I would say that the initial management that has been recommended is actually still persists. I mean, he does actually have active inflammation, and maybe this actually can help him decrease some of that inflammation, maybe open up some of that stenosis. The presence of fistula could also be in the presence of obstruction. But that being said, I'm not optimistic, to be honest.
Yeah. So would you favor surgery or medical therapy up front?
I would say that if there are actually any considerations or thoughts that this may actually be due to fibrostenotic disease, then I would actually favor going for surgery. If we think that this would be amenable to medical therapy, even downstream, then we could actually continue pushing that way. But at the moment, it seems like we're potentially moving or very rapidly marching towards surgery.
In my experience, ileosigmoid fistulas are almost always secondary penetrating disease from prolonged fibrostenotic Crohn's. Mm-hmm. And these patients do best when they have surgery and get a fresh start. The other thing to know is that after a resection and patch of the sigmoid, they don't get this again. Mm-hmm. Even if they have recurrent Crohn's, the planes of tissue and all the connective tissue that was leading to some of this has been just dissected away. So they can have recurrent Crohn's, don't get me wrong, but they don't get that again. Classically, when you do the colonoscopy on somebody with an ileosigmoid fistula, it's always in the same place. So for those in the room who've done it and seen it, you know where it is. It's as you make your turn into the sigmoid, it's off on the left at about 9 o'clock. It's always in the same location. And when you see a relatively spared sigmoid with just one area of inflammation, even if you don't see a clear hole in the bowel, when there's that focal area of inflammation in the sigmoid as you make that turn, you should always wonder about whether that's going on. And you can tell on exam, physical exam, you can tell when you image them. This is classic of somebody who's been walking around with stenotic disease. And I agree with Ray's initial assessment that surgery is probably best here.
Okay, great. So he's tried a low residue diet, his pain increases again, CRP starts to increase, his fecal calprotectin you get back from 2 days before was at 791. So I'm going to go on actually. So we talked already about the fact that we think that the surgical therapy up front would be best for a patient like this. So this is what we did present to the patient, but he was quite resistant and did not want this. So I think we already also discussed the fact that upstream dilatation on bowel imaging does suggest that this patient has more of a fixed stricture that might be that won't necessarily be amenable to medical therapy. But let's say this is a patient who is really going to want to try medical therapy first. He's actually not, he just was diagnosed a month ago, and the idea of surgery, I think we've all seen this before, so early on, sometimes does not sit well with our patients. So if we do consider medical therapy, do you feel that all agents are considered equally as first-line agents? What are your thoughts?
Well, I think if it's an inpatient, you really only have one choice. Mm-hmm. You have infliximab, and that's fine. There's not comparative effectiveness studies other than thiopurine to infliximab. So I don't know that we know that one is better than the other. Some people feel that vedolizumab doesn't work as well for small bowel Crohn's disease. I would say that nothing works as well for small bowel Crohn's disease in general. I don't think it matters. I think you pick one. Everyone has their favorite. Again, the payer is going to decide what you're going to use first anyway, most likely. And I think coming back to the point is, if you give a drug, I'm fine, but just don't give drug 2 or drug 3.
Gotcha.
Just make a decision in your mind, like, I'll try one thing, and if they have this dramatic response, that's great, but don't keep burning through drugs. Because that's, in our referral practice, we see that a fair amount, unfortunately. Mm-hmm. We burn 3 different classes of drugs for fibrostenotic disease. And by the way, University of Michigan looked at this with strictures. When I was a trainee, there was this concept that you had 2 types of strictures. You had inflammatory strictures that were reversible with medical therapy, and you had fibrotic strictures which needed surgery. The reality is that most strictures are mixed, and those that are most fibrotic also have the most inflammation. So this concept that there's a pure inflammatory versus pure fibrotic, that's why the Calpro and the CRP are still up. They're not really purely fibrotic or inflammatory strictures.
It's easy to be on a panel and say, oh, we should just do surgery. But the conversation I have with patients, and when I see them for a second opinion or when I admit them and manage this, is that I tell them that of all the things we've done in Crohn's, the most significant advance I think that we've made is prevention after surgery. I think we've done the best job at knowing how to monitor and what to do, and I really feel strongly about that. And we're so far behind the game here trying to catch up with somebody who's had disease for years. This isn't really a new disease. It's the diagnosis is finally clarified. So it's no criticism at all to the clinicians having these conversations with the patient. But this is a surgical disease right now.
Right. So the patient starts on antibiotics, feels much better,
course.
And then infliximab.
But remember that I'm sorry to interrupt.
No,
remember my point about activity versus severity. This is going to happen. So, okay.
Yeah, absolutely. I think these are important points. Again, we've all seen these patients who go through multiple biologic therapy and they may have some partial response, but in the end, when a lot of bowel damage has already occurred, sometimes an upfront strategy of considering surgery or at least counseling a patient to consider surgery earlier is necessary. So he does start an infliximab at 5 milligrams per kilogram in the hospital. He remains NPO for about 2 more days, and he goes home on a polymeric liquid diet, and then he does this for about 3 to 4 days. Then he says the elimination diet really is what's helped him. It's not really the infliximab. He kind of forgets that he received that medication. And he says, it's my diet.
Yeah.
So I'm going to
anything.
have Berkeley, Dr. Limketkai, start talking about dietary therapies in IBD. So I'm just going to ask the panel before that, though, do you ever consider a trial of dietary therapy before biologics in or before any Crohn's therapy in a patient who really want to try dietary therapy? Is there any role for that?
I'm not opposed to this concept. So first of all, we had wonderful lectures in the earlier sessions with our colleagues in the functional sessions. But first of all, I say to patients that when you're trying elimination diets and nothing seems to be the exact cause of your problem, that's because it's the bowel, not the food, which is often the case in a Crohn's patient with stricture. Secondly is that I'm not opposed to them trying it. The data actually exists for pediatric Crohn's, right? An elimination diet, or even the gastro paper recently in a partial elimination diet or elemental diet can be effective for small bowel Crohn's. It doesn't work for colon. And the message is the same. If you're going to do it, then do it and make sure you have a plan. 6 weeks later, reassess. If you're actually getting what you need out of it, that's fine. Just remember also that our goal is quality of life. And for some people, I just met a 17-year-old last week as a new patient. He's on the specific carbohydrate diet. He also has active disease, but he's feeling better, right? But he's miserable. He hates the food. Mm-hmm. And it's not a sustainable plan. So you have to have a full conversation. And we definitely are learning more about the RFID problems in our patients with IBD.
Okay, great. And with that, I'll have Dr. Limketkai talk about dietary therapies.
Okay, thanks very much, Dr. Sauk. Just before I start, I would just want to also provide the disclaimer that this particular talk does not necessarily focus on that patient that we just discussed, in the sense that in that patient, I don't necessarily recommend dietary monotherapy. But for any of the clinicians in the room, and particularly those who take care of IBD patients, a very common question asked is, what can I eat? The challenge with that question, however, is that the patients are faced with a litany of information and misinformation, particularly from like the internet sources, social media, friends who now claim themselves to be experts in nutrition, in the clinic and in print, and a variety of sources of information which may or may not be misleading and confusing, and it just illustrates how muddy of a topic this is. But before we actually dive into some of the details about what the available evidence are, let me at least touch on a framework of how nutrition relates to IBD. So in the concept of pathogenesis and then of IBD and then eventually disease activity, we do at the very least know that disease activity can actually worsen nutrition. In the setting of the catabolic process of inflammation, intestinal malabsorption, altered dietary intake, as well as iatrogenic reasons, such as when we place patients on NPO for tests, procedures, and so forth. The flip side of this, however, is that nutrition may also influence disease activity itself. So through a variety of mechanisms. In the interest of time, I will actually not go through all of that in great detail, but let's just say at the very least that there are multiple potential mechanistic approaches of how that all relates to each other. So the question then is, can diet be a cure? So we actually performed a systematic review looking at all the randomized trials of dietary interventions in both Crohn's disease and ulcerative colitis. We published in the Cochrane Review, and we actually unfortunately found that there was actually no diet found to be helpful for induction of remission or even maintenance of remission in either Crohn's disease or ulcerative colitis. In addition to that, we actually found in a pooled estimate that this is not present, and the recent guidelines from the European Society for Clinical Nutrition and Metabolism had also written that there is no quote-unquote IBD diet that they would recommend for either induction or maintenance of remission. Now, that being said, what do the evidence show? So there are certain things that I would actually stratify as one being established evidence, being information or evidence that has been shown to prove either the benefit or lack of benefit thereof of dietary therapy. And then second, what I would call emerging evidence, whereby there are studies and upcoming data showing potential benefit, and extrapolated evidence where the information or hypothesis of a relationship is present, but we don't yet have the data to show one way or the other. So what, Dr. Rubin had earlier mentioned about this use of exclusive enteral nutrition, particularly in the pediatric population, and even the European guidelines now even state that this is an effective form of therapy for induction and maintenance of remission in Crohn's disease. And the European guidelines have additionally recommended as a first-line treatment, particularly when they need to have corticosteroid treatment strategies. The challenge, however, that the adherence is actually fairly poor. You can imagine. We actually went to lunch earlier, and then we ate, the whole slew of different types of foods. We eat for social reasons, we eat for taste, we eat for nutrition, and for a variety of reasons. But imagine yourself having to consume the same, oral supplement or something via tube feed for not just like every meal, but for days on out, or maybe even months on out. That's quite the challenge. So the next question then, and also as alluded to earlier, is what about partial enteral nutrition? So this was recently published in Gastroenterology. It was a study performed, multi-center study, led by a group in Israel, and they also had collaborators in Amsterdam, where they actually looked at partial enteral nutrition, so taking the concept of this exclusive enteral nutrition and then combining it with a solid food diet. In this case, they actually used something called the Crohn's disease exclusion diet, where they excluded things like animal fats, wheat, dairy, red meats, emulsifiers, and food additives, and by contrast, recommended the increase of fruits and vegetables. What they found in the first 6 weeks of when they compared exclusive enteral nutrition to partial enteral nutrition was that there was actually no difference in the rates of induction or remission and in all the other outcome measures except for tolerance, whereby those receiving parental enteral nutrition had improved tolerance than those who had exclusive enteral nutrition. Again, not surprising given that we like to eat our food. What they then did is they actually extended this trial to the 7 to 12 week mark, where they, in this case, for those who are actually on the exclusive enteral nutrition, they placed them on just 25% of enteral nutrition and then 75% standard diet. And they compared those who actually received the Crohn's disease exclusion diet. And interestingly, they actually found that those who actually received the Crohn's disease exclusion diet had better sustained remission rates than those who actually were on the standard diet. Now, why am I saying this? It's because it actually does illustrate how potentially some dietary therapy may be helpful for maybe inducing and sustaining remission over time. And then we also heard about the specific carbohydrate diet, and it's the premise behind this is that when we actually have carbohydrate malabsorption, it then leads to bacterial overgrowth, and the byproducts of the bacterial overgrowth, as well as its presence, leads to progressive small bowel injury. Small bowel injury then leads to subsequent increase in the malabsorption. So the diet actually recommends the consumption of monosaccharides, and the reason for that is because they are quote-unquote theoretically more easily absorbed, and as a result, you actually quote-unquote break this vicious cycle where there is less carbohydrate malabsorption. Now, with regards to the data, unfortunately, despite it being a very popular diet, or had been a popular diet, the data, unfortunately, have been so far uncontrolled and not very convincing for showing efficacy, and not very high quality of evidence. So what do we have thus far in terms of evidence? Now, this is hot off the press from the International Organization for IBD, where there was a 12-member panel in their nutrition subgroup, and they scoured the literature and tried to identify different food groups and the available evidence, and hoping to actually provide recommendations that we can also share with our patients. So what they found for fruits and vegetables in Crohn's disease was that it's probably prudent to increase consumption of that, except in a patient who actually has stricturing disease, naturally. Keep in note, however, that this is actually of low quality of evidence. Now, in terms of looking at it for ulcerative colitis, we actually do not find any evidence of any benefit, at least in terms of the amount of data present. And then we also looked at refined sugars and carbohydrates. We typically tell our patients to reduce that, but unfortunately, there's actually insufficient evidence. Wheat and gluten, insufficient evidence. In terms of red and processed meats, they found that you actually do not need to decrease red and processed meats necessarily, but for ulcerative colitis, it probably is prudent to actually decrease it. Now, for poultry, and no clear evidence. For pasteurized dairy, they were unable to reach a consensus. So some of this is still relatively controversial. For unpasteurized dairy, although there was no evidence to say yay or nay, expert opinion states that it's probably wise that the patients do not consume it. And then in terms of dietary fats, as well as food additives, there is some evidence to show that we should not be consuming, or they should actually reduce it in patients with IBD. So that being said, just to recap, we need to be vigilant about patients' restrictive eating and unintentional weight loss, particularly given how intestinal inflammation and altered dietary intake can lead them to increased malnutrition. We would recommend to partner with your dietitian to help them with their malnutrition and in all the other nutritional approaches we have with our patients. Exclusive enteral nutrition has been found to be helpful for induction remission, but we do also note that it may be challenging to consume. Now, in terms of solid food diets to recommend to our patients, I shared with you a graph of things that we may be prudent to increase and may be prudent to decrease. If we look at it from the standpoint of the different diets that have been recommended thus far, we will note that they actually share a lot of very similar principles, right? So the principles of increasing your fruits and vegetables, decreasing red processed meats, food additives, emulsifiers, and so forth. And some of the prototypical diets right now that are floated in the medical community are either like plant-based diets, Mediterranean diet, Crohn's disease occlusion diet, and specific carbohydrate diets. Now, while I share with you the fact that these actually may have some evidence of benefit, the thing that we have to also keep in mind is, the context of the patient, right? So similar to the case that we just described earlier, although I'm sharing you information about how the diet may be helpful, we have to keep in mind that the diet is not necessarily a monotherapy, and we still need to consider the backbone of either pharmacologic or surgical therapy. And my final point, so much more research is needed.
Right.
Thank you.
Fantastic. Thank you very much. Okay, so I'm going to kind of go through the case a little more quickly because I want to get you guys out by 6 if possible. So 2 weeks after the hospitalization, he remains on infliximab for 5 mg per kg every 8 weeks, and he started on 6-MP as well. He's on combination therapy because we are going in that direction right now, despite the fact that it wasn't necessarily what we had originally wanted for him. His CRP does improve, and he still feels well. So now 1 month after hospitalization, he's doing great. He feels fantastic. I was surprised. So as Dr. Rubin says, sometimes we're surprised, right? We all think that this patient should have gone to surgery, but he actually has done quite well. So when would you see him again? What's your monitoring strategy for someone like this? Dr. Rubin, monitoring is super important.
When I start any therapy, I schedule a follow-up at between 6 and 8 weeks. Mm-hmm. If it's a biological therapy, it's after they finish their loading phase of whatever that is. To make sure we have them plugged in. And once they reach maintenance phase, if they're stable, I will do it every 6 months. If they're not stable and we're making adjustments, then it's more frequent.
Okay, and do you check, Dr. Cross, thiopurine metabolites and infliximab trough levels?
Yeah, so I would have checked a week 6 level on him, and then for thiopurines, if I'm using them, if I start a thiopurine, I'm usually trying to use it to get to therapeutic levels as well. I'll check a thiopurine level at week 4 when it reaches steady state.
Okay. All right, so we did check that. So his week 14, we checked his serum infliximab. It was at 11.5. His 6-TGN is at 131, so it's appropriate for combination therapy. So overall, he's looking pretty good, right? So would you make any changes at this point or leave him alone on autopilot? Dr. Limketkai?
Yeah, oh, well, I mean, the good news is that he's actually doing well at the moment. In terms of his thiopurine, I would not necessarily change it. In terms of his infliximab, it's 11.5. It's a little bit higher on the higher side at the moment, but I would probably keep him on until I feel that he's relatively stable, then decrease it once it's in the maintenance, or stably in the maintenance.
Okay, so he's on already 5 every 8. So I think at this point, he's doing well. I think he's doing well. So we have a colonoscopy done. Would you perform a colonoscopy on him to see if there's any? Now he hasn't had one at baseline with us. It was at another institution. So do you think that looking is important?
I would.
He's a high-risk patient.
Yeah.
I wouldn't look before 6 months, but I would look.
Mm-hmm. So we took a look, and the colon looks great. It's all healed. And as Dr. Rubin mentioned, there's that little pile of pseudopolyps in the sigmoid
right
from
there
that
on the
fistula.
left.
Absolutely, you guessed it. You got it. So it's right there. And then the ileal opening, it's present. You can't get in. So you can go. Maybe this is what happened in his first colonoscopy. I mean, they could get in the first 5 centimeters, but you can't really push further, advance beyond that. And so this is still the case now. So there's not any inflammation that you can see in the ileal opening, but when you try, there's a sharp turn to the right, and you can't make it through.
Just as a pearl, remember that fistula is a tract, and so if he obstructs more, he may actually have diarrhea shunting into the sigmoid and avoiding the entire colon. So if he starts having watery stools, that's in your list of possible explanations.
Interesting. So now we can't get into the ileum. What would you do to monitor this patient? You can't see whether or not the stricture is better. Or
Well, we know his CRP is okay and his drug levels are okay. The question is whether you want to order the monitor test from Prometheus, which is the 13 molecular and genetic markers. I don't know that I would do that necessarily. The recommendations have been to consider cross-sectional imaging follow-up to see if there's improvement in the wall thickening or in the proximal dilation, which, as Ray said, is probably not going to improve dramatically.
Exactly.
So you can just decide on what you want to do here.
So exactly.
You can also just reach through there with your forceps and grab a few biopsies of the ileum beyond where you can see.
The other question is, what are you going to do with the results? So if you do this imaging and it lights up and there's hyperenhancement.
Increases infliximab, no?
Well, the infliximab's already 11, and now you could increase to 6 MP.
Well, one of the things about levels is that in my practice and the way I'm thinking about these things these days, I will, as long as there's not a level that's too low where the risk of losing response or developing antibodies, I will go up if the disease is active, if there's room to adjust within limits of the drug. So, for example, if I thought he still had active ileitis or other findings, the level of 11 wouldn't be enough to dissuade me from trying 10 milligrams per kilogram a couple times.
Okay. So we also check a calprotectin. So there's still a little bit of inflammation in that area. So that's a question that I was wondering. Do you optimize this? Do you say, that level of 11 should be enough?
I don't
right? Do you
know.
leave him alone? Everything's good?
Well, remember the Schnitzler study that they did showed that you didn't have to get complete healing
Right.
to prevent surgery. Now, I think this kid's going to have surgery in his lifetime no matter what you do. I think that's 100% certainty it's going to happen, but because he's so young. But if your goal is just for it to look better, you have a baseline scope that you didn't do that
He's
showed
much better.
ulcerations, and he's healed, and his markers are better. And so you got one marker that's not completely normal, but in the COM study, they used 250 as the cutoff, so that's pretty close to the cutoff. So
You
Let's say it
also
was
only
higher.
have one data point since you started therapy. So another option is, he's doing so much better. Encourage him to continue his diet or do something there and give him positive feedback and then plan another follow-up exam of some kind, not necessarily all of this, but
Great. So
something.
he's doing better. He's in remission, and you say exactly what you mentioned, that he's made a lot of progress, and you leave things alone. So you won't do anything else to optimize his therapy at this time. He does have one obstructive episode, so Dr. Cross called it. And at this point, how many of these obstructive episodes is he going to need before you decide he's going to go to the OR? So he has one isolated episode. He says he's been a little more liberal with his diet. He attributes it to adding cheese to his diet. But you also find out that he decreased his 6-MP. So he actually, you're not even sure if he's taking it. His CRP does elevate. This is not during the obstructive episode, but this is now after. So how would you counsel him now? He's better now.
We know from David Binion's work on silent Crohn's, it was exactly this. It was patients who were feeling pretty well but had persistent CRP elevation, and the most common thing that happened to them compared to those who did not was hospitalization for small bowel obstruction. Mm-hmm. So if you're looking for evidence to guide you here, that CRP is a harbinger of something that's going to happen, and you already know its history, and we already discussed that we thought surgery might be necessary, so we're getting there.
Okay, so he's concerned about his 6-MP. So he really is he doesn't really take it, right? You check a level and it's decreased now at 4.5. You decrease the interval a little bit, and you want to see if you can maybe boost that up, because you're pretty sure he's not taking his 6-MP. He doesn't have a thiopurine metabolite level checked, and sure enough, when you get to 5 milligrams every 6 weeks, he's doing a little bit better. His CRP improves. He doesn't get his calprotectin done for you. You check his level again, is at 7.3. So I do check levels quite frequently in someone like this, where I'm a little concerned about compliance for him. He does better. And you check his 6-TGN, and as you realize, it is low, so he's not taking his medication. So young male, single, high chance of non-compliance to infliximab. So this guy, you find out, you get labs on him whenever he gets an infusion, but you noticed actually that he's spreading out his intervals without telling you. So he goes out to every 8 weeks, and again, his CRP is starting to increase again, and he's basically on monotherapy. And you can tell that he's actually getting more inflamed. And you call him out on it. You let him know, I said, look, I think your inflammatory markers are going up. I think you're going to still need your infliximab if we're going to be going this route. He knows that he's a high risk for surgery. He still doesn't schedule his next appointment until 9 weeks later. And you find out before you check that level one more time that now he has this double positive funny scenario. What is this? So, if you have a mobility shift assay for infliximab, sometimes you might get this scenario where you can still see drug level present, but you also have low level of antibodies. So someone had asked this question earlier, if you have low antibody levels, is there anything you can do to try to overcome that, or what do you do with this scenario, Dr.
Well, there
Rubin?
are 3 explanations for this finding. Number 1 is that he's starting to develop neutralizing antibodies, and you caught them on their way up and the drug level on its way down. And so a second assessment a month later or 2 months later is going to show you the trend. Number 2, that these are transient antibodies, which we don't fully understand, but they will go down on their own. But obviously you're worried because his infliximab levels drop, so you're worried that these are in fact neutralizing. And the third possibility when you see this in practice is that these are not neutralizing antibodies. Some of those antibodies are picked up by these assays. And that's usually the case if you have something like this, but the infliximab level is still over 10 or where you want it. So in this case, you're suspecting that he's starting to develop neutralizing antibodies, and if you just did another one in a few weeks, you would see the trend. If you want to suppress this, you can increase his infliximab and give him an early dose with pre-meds. You can add back his immunomodulator, switch him to methotrexate. There's enough data from a couple different experiences that will suppress this. If you're going to do that, then you have to repeat the drug level and antibody assessment after you've put them on another drug and they've gotten 1 or 2 more cycles of therapy.
Okay, so in the interest of time, we increase his infliximab to 7.5 mg per kg every 6 weeks, and we add methotrexate. So unfortunately, he's not taking the methotrexate. 4 to 5 weeks later, he has migratory polyarthralgias. He's not feeling well. You check his level, and he has full-on antibodies now. And his CRP is up. You treat, from the bowel perspective, though, he feels fine, weirdly enough. He doesn't feel obstructed, but you give him a short steroid taper for the joint pains. He says, you know what, I want to see how I do off medications. I think I don't need it. I saw I healed. So how do you counsel him on this? What do? You say yes? Or do you say...
If he wants... So... I'm interested to know about the polyarthritis, whether that was a lupus-like reaction from the infliximab or whether that was an inflammatory arthritis, but he's better, so it's a moot point.
He's a little better,
off
yeah.
drug.
Mm-hmm.
So if he wants a drug holiday, just do an ileocolic resection. He might do well for a decade without any medicine. He gets into his 30s when he's more mature, stable environment. I would sell it to him like that. Listen, dude, if you want to be off drugs, let's just take this bad segment out. You don't have to restrict your fruits and vegetables and nuts anymore. You can eat what you want. We'll do a scope in 6 months, and if it looks good, we'll continue to monitor you. That's our negotiation, no meds. But, there's a cost. You have to have a little scar. I think that would be perfect for a young guy like this. He's demonstrated he cannot take maintenance therapies well at this stage in his life.
Right. Okay. So sure enough, he has about 10 weeks out after he stops all his therapies, he gets obstructed. So, and he has an MRE at that time, bowel wall thickening, everything that works. He has upstream dilatation. At that point, he's ready. He's ready for surgery. So he has an ileocolic resection performed, a fistula takedown, 20 centimeters of the ileum removed. So we've already kind of touched upon all these issues. If he were compliant, it's possible he may have avoided surgery, but as Dr. Cross said, this is probably inevitable in his future at some point. And then when would you start postoperative prophylaxis after surgery?
So we start, it depends. So if the infliximab, if you didn't have antibodies and you were going to go back to that, you could start it as soon as you could get it scheduled. We have data that even within 2 weeks of surgery, it's safe, but most of the studies are within a month of surgery you start. So I think that would be your goal. And then I typically do a 6-month scope. I think David may do Calpros or something earlier than that, but I just do a 6-month scope.
It sometimes depends on the pathology specimen. I've gotten in the habit now of going to the path lab and looking at the gross, and when it's just big scar with some surrounding inflammation, I often will let those patients rest a bit and reevaluate at 3 or 6 months and try to make decisions as we go along. Now, he's at high risk for recurrence. This is a young man. He's had disease since he was young. He's had penetrating complications from fibrostenotic disease. He is going to have recurrence. It's a question about whether the utility of therapy and the relative risks and benefits, as well as his personal choices, will be worth it to try and convince him to be on drug, as opposed to if you do nothing. Look at the natural history of his disease that led to the point where he finally got diagnosed. As Ray said, it might be years before he ends up needing anything, and by then it might be better for him to have another limited resection, frankly. So there is a way to figure this out and to try to convince him to let you monitor him. You just don't want it to go too long, and I'll show you that one slide. I have an abbreviated version of my presentation so we can finish up.
Yeah, okay, so we're gonna finish up soon, but just wanted to ask what you would consider for postoperative prophylaxis in this guy. So combination therapy, monotherapy, anti-TNF therapy.
Well, if he was letting me drive and there was inflammation around the stenosis that was active, then in my practice, I send him home on low-dose metronidazole. I do a fecal calpro at 3 months. I scope him at 6 months. And if there's anything more than grade 1 recurrence, I will put him on biological therapy. And at this point, I'm not sure if he still needs to be on directly observed therapy because he's so non-adherent, but I would normally want to consider ustekinumab after this. Okay. That would just be my general approach because it offers some convenieence and I'm comfortable with the safety profile.
And what about adalimumab? Would you consider that?
It's an option, but there's nothing wrong with doing that.
And then in someone like this, combination therapy, not something you feel like you need?
Well, he's an antibody.
Yeah, he is an antibody former, right?
That's the advantage of David picking ustekinumab, is you probably don't need to do a second agent with that drug.
Excellent. Okay, so you're gonna go really quickly through some of the summary slides. Thank you.
You know what? I'm not going to give a full talk. I'm just going to show the audience a couple new things. And Ray was nice enough to present the PREVENT trial. So let me just get to a couple things that I thought the audience would want to see. First of all, this is the nice work that was done also by Laura Glick in our group looking at low-dose metronidazole as a prevention of recurrence of Crohn's. So the general concept for those in the room who remember is that high-dose metronidazole is very poorly tolerated but did prevent recurrence of Crohn's. So the issue was, could you use low dose out of the hospital as a bridge to something else? So it's the same story. I had been doing that in all my patients and my partners weren't, and we looked back at how they were doing and adjusted for other risk factors, and we found that it actually had significant reduction in recurrence. You've already heard about some of the data with infliximab, but let me show you the follow-up to that small study, the original placebo-controlled trial that Miguel Reguero did. I've always really liked this. So at the end of the one-year study that Miguel did that showed that infliximab was better than placebo at preventing recurrence in high-risk patients, and you see it's a very small number of patients. The interesting thing was at the end of the year, they allowed patients to either continue their infliximab if they were on it, continue or go to infliximab if they had been on placebo, or stop their infliximab, or stay off of everything. And then this is what happened to those patients, and I just want to show you a couple things. The people who got placebo in Miguel's study, who had recurrence, that's what the 2s, 3s, and 4s there, who got infliximab after they'd had a whole year of being on placebo, they couldn't really heal them. You see that their post-infliximab treatment on the right column there is still 2s. You couldn't get them back. The point here is if you wait too long, you can't recapture people. It's a very important lesson. And even in the patients who were randomized to infliximab in the study, you see that if you continued the infliximab, you did okay. But if you had recurrence despite infliximab, the very bottom row there, you couldn't get them back if you gave them another year of infliximab. So timing matters here. If you wait too long and the patient has too much recurrence, the drugs don't work as well. So monitoring is the key message out of all of this. And you saw the PREVENT study, a similar study to this general principle, but getting back to what Jenny just said, is an Australian study called POCR. It's spelled POCR, but they call it POCR. And it was stratifying adalimumab based on a 6-month colonoscopy. So if you're going to do something, make sure you do it no longer than 6 months, and then you can start people on therapy. And they demonstrated that what they called the active treatment and the adjusted treatment, it worked better when you did that at 6 months than doing nothing. They also showed in that study very nicely that calprotectin at 6 months had a good predictive value, negative predictive value. Okay, so moving on, the only other thing I wanted to show you, 2 things, is this. This is called the LYRIC study. And very annoyingly, it is spelled with an exclamation point. That is their title of the study. But LYRIC took patients newly diagnosed with Crohn's who were not obstructed and did not have proximal dilation. So it's not this case. But they were newly diagnosed with Crohn's, and they randomized them to a laparoscopic ileal resection or to infliximab. And the primary outcome was quality of life at a year. And the patients who had a laparoscopic resection had a better quality of life, and they were less expensive. So this was an argument that at the time of diagnosis, by the time patients finally make their way to getting diagnosed with Crohn's, taking out that segment of bowel that's been there for years before they made their way to our offices might be the best way to get control of the disease. Now, this is only the 1-year outcome. The remission rates were the same. This is what the graph shows you there. So it wasn't necessarily that much better. But from the cost and quality of life point of view, getting rid of that segment is probably good. So the whole point is getting rid of the disease and then preventing it from coming back. And you know the patient has a risk of it coming back. That's a common feature of Crohn's. I'm not going to take you through all this. I'm just going to show you one other thing. One of the biggest things that's come out in the surgical literature now, and it was actually done by gastroenterologists, is something called the Puccini trial. Puccini wanted to answer the question, does perioperative infliximab increase risk of complications postoperatively? So what they did here is they actually had patients who either got infliximab within 12 weeks of having surgery, most of it was ileal resections, or had measurable infliximab levels before having surgery. The bottom line was having infliximab on board before surgery did not change outcomes, and that's why all these bars are aligned, blue and orange. So the point here was that it was not dangerous to have tried infliximab and then sent them to surgery. The outcome is going to be the same in terms of risks. And by the way, that's a pretty high risk. There's a 20% risk of infections and other problems. So I'll end with this slide and get us hopefully wrapped up. This is an algorithm, and the way you approach prevention of post-op Crohn's is exactly what we've been going through. What is the risk or likelihood of recurrence? If you know that it's low risk, like the 50-year-old who presents with a stenotic obstruction, and they probably had disease for 30 years before you've stumbled onto it or they developed an obstruction, you probably will do nothing but do a colonoscopy at 6 months. If they're high risk, a young person presents with a secondary penetrating complication and fibrostenotic disease or anything else going on, consider early monitoring, calprotectin at 3 or 6 months, scope everyone at 6 months, consider putting them on therapy right away. You can stratify, and low-dose metronidazole out of the hospital has some benefit as a bridge strategy. But as you heard Ray say, and I agree, you can start people on therapy as early as a month or 2 weeks post-op if you want, and there's no danger there. So make sure you're thinking carefully. Same message as what I gave in the beginning today. What is their risk for badness or for poor outcomes going forward? Stratify, monitor, monitor, monitor. And I know that patients don't want surgery, but communicate about the benefit of it. I often say it's like hitting reset. You get a second chance, and this time we know you have Crohn's, and we're going to do a much better job. And it's much easier to prevent than to treat things that are all already there and have caused damage. Thank you.
Okay, so we're almost done. I'm almost done, pretty much. So we started him actually on adalimumab and methotrexate. The concern with ustekinumab, is there a lot of data for postoperative recurrence? We don't know yet, right? So I think that's where a little bit of limitation was there. But that is something we may consider in the future for him. Did his colonoscopy, looks great. So there's nothing in the ileum right now.
Diet's working.
Diet's working. All right, with that, thank you very much. We're going to just have some few take-home points. Skip mesalamines and Crohn's. And if choosing the medical option, treat early with biologics, but consider surgery early. It's still an option for short segment stricturing Crohn's. Concomitant dietary management is an important way to increase patient engagement, and proactive drug monitoring can help understand the reasons for treatment flare. And post-op prophylaxis based on risk and colonoscopy 6 months out after surgery is optimal. Don't wait until symptoms. Thank you guys very much. Thank you. Thank you to our panelists. Really appreciate it.